Welcome to the Laboratory Training and Services Branch webinar, Human Brucellosis Associated with Brucella Abortus RB51, Shedding in Milk, a New Problem. Today's webinar speaker is Rebecca Tiller. Rebecca Tiller is a microbiologist in the Bacterial Special Pathogens Branch, Zoonosis and Select Agent Laboratory at the U.S. Centers for Disease Control and Prevention. She has worked in the National Brucella Reference Lab since 2007. Ms. Tiller has extensive experience working with Brucella species in areas of microbiological and molecular characterization, including whole genome sequencing and MALDI-TOF applications. Everyone, please welcome Rebecca Tiller.
Okay, thank you, everyone. I appreciate all of you calling in the week before the Christmas holiday. So I'm going to talk to you today about human brucellosis associated with Brucella abortus RB51 shedding in milk, and if this is a new problem. So I've broken this presentation down into 3 different sections, and the first section will just have a general background on the epidemiology of human and animal brucellosis in the United States. The next section will be about specifically the Brucella abortus RB51 vaccine strain and the recent human exposures that we have been dealing with here at the CDC and in localized state areas. And then the third section is specifically on laboratory diagnosis of human brucellosis and the challenges with Brucella abortus RB51. So the first section will be background on the epidemiology. So brucellosis is a worldwide zoonotic infection. It's estimated to cause over 500,000 human infections globally. It has many clinical manifestations, and it can often localize and cause chronic infection in humans if it's not promptly diagnosed and treated. In animals, it is an economically important disease. It causes infections and abortion in livestock. And 3 of the Brucella species are regulated by the Division of Select Agent and Toxins due to their consideration as potential bioterrorism agents. So these are the main Brucella species that have been identified, and I have one circled here because this is a particular species that we're going to focus on in the talk today. But over the years, there have been many new Brucella species that have been discovered and identified, and in fact, there are 2 species that are missing here, Brucella vulpes and Brucella papillonis, that are known to have been recovered from non-human primates. So for the purpose of this particular presentation, we're going to focus on Brucella abortus, but Brucella canis can infect humans as well, and its primary hosts are dogs. Setae is cetaceans, dolphins, porpoises, whales. B. inopinnata was an unusual case isolated from a human breast implant. There's only one of these representative isolates in the world. And this particular isolate was recovered from a patient in Oregon. B. melitensis is very, very well known and common, and its primary hosts are goats, sheep, and has been identified in vectors in a stable fly. The other main species that infect humans are Brucella suis, which we have in the United States in our wild feral swine reservoirs. But it can also infect reindeer and caribou, and it's also been detected in rodents and foxes. So these are the main modes of transition for Brucella abortus, and many of the detection and eradication efforts with brucellosis have been focused in cows. So there are artificial insemination transmission pathways from a bull to a cow, and then from cows you can have transmission to humans and other surrounding cattle via exposure to contaminated parturition material, fetal, placental, vaginal secretions, and things like that. Environmental contamination is more common between animals. However, the organism itself is known to survive in the environment for a certain period of time. So there is some risk to humans that may come into contact with Brucella species that are deposited in the environment. So again, so we'll just focus. These are the four main species that infect humans. It's Melitensis, abortus, suis, and canis. And these images are pictures of their primary hosts. And this schematic picture is of the main routes of transmission to humans. And vaccination is definitely considered a risk, and laboratory exposures, slaughtering swine and animals, veterinarians, and exposure to infected dogs, and then consumption of raw dairy products is the most common route. So person-to-person transmission is considered very rare. There have been some documented cases of it, but it is not very common. So this is the manifestation of brucellosis in humans, and it can involve many organs. So it can become quickly a systemic infection. It initially localizes in the regional lymph nodes. You have a bacteremic phase that lasts 2 to 8 weeks. In which the bacteria invade the macrophages, and the macrophages release, they burst open, and then they release the bacteria into the blood. And so you have these undulant fever, which is one of the names of brucellosis is undulant fever, Malta fever. Well, so most brucellosis patients experience severe flu-like symptoms with muscle aches, chills, fatigue, weight loss, arthritis, meningitis can occur, endocarditis, and Brucella species are an intracellular organism, so it can be difficult to, with the standard regimen of treatment, to cure an acute infection. And sometimes you have residual infections that relapse and then eventually could potentially develop into chronic brucellosis. So the CDC guidelines for treatment for brucellosis for uncomplicated cases is a dual regimen of doxycycline and rifampicin for at least 6 weeks. If there's contraindications with with the rifampicin, streptomycin can be replaced in those situations. For pediatric patients that are uncomplicated, doxy and rifampin for children older than 8 years old, and then trimethoprim sulfate and rifampin for 6 weeks. If brucellosis is not diagnosed promptly and initiation of therapy is delayed, then you can have a relapse. And then sometimes the antibiotics, especially with a dual antibiotic regimen, can cause some side effects, and some patients discontinue their therapy, and that can also lead to a relapse and infection. So this slide is, I just wanted to give a history of where we have been with brucellosis in the United States, and then bring you forward to where we are now and how, vaccine strains have played a role in the eradication of brucellosis in the United States. So this is a USDA map of the infected herds in the United States in 1957. So we had about 123 plus thousand infected herds, cattle herds in the United States. And to the right is a prolonged time chart looking at the decrease in human cases along with cattle cases. So this is just a really good image for us to really see the direct association of um, treating or handling the disease in animals, and how it can affect and directly affects the decrease in human cases over time. So the history of eradication of brucellosis in the United States really started in the 1930s when the Brucellosis Eradication Program was implemented. And it was implemented at the state and federal level in all states in the United States. The approach was just to test and remove any diseased cattle. And at that point in time, there was about 11.5% seropositivity rate in the United States. The program expanded in the 1950s, and brucellosis was considered the most significant livestock disease in the United States. And per the slide prior to this one, there were about 124,000 positive herds in the U.S. in 1957. And again, the approach was to test, slaughter, trace back to the herd, investigate, and then vaccinate. There were also laws that were implemented, such as the Pasteurized Milk Ordinance in 1924, to protect consumers of milk products. So steps towards surveillance eradication involved some pretty rigorous surveillance, which was critical for the eradication program. And there was a lot of consideration into what went into the surveillance of brucellosis. They needed to have appropriate tests, and they needed to have down-the-road testing of herds. They needed to collect blood samples at slaughter. By the mid-1970s, they were doing blood testing of cattle at assembly points and livestock markets. If an infected animal was found, the herd was traced back to and positive animals were then removed. So the eradication program was largely successful due to the use of animal vaccines. So there is no human vaccine for brucellosis, and between the 1930s up until the 1990s, the predominant vaccine strain was the Brucella abortus S19 vaccine strain. And then after, in the 1990s, came the Brucella abortus RB51 vaccine strain. Both of these vaccine strains are attenuated vaccine strains, and they do provide protection, though incomplete, from infection. It does decrease the shedding of organisms, but it's not protective across the species. So a Brucella abortus vaccine will not protect a cow that could be infected with Brucella suis from exposure to feral swine, for instance. So there are complications from vaccination, those mimicking similar symptoms from a natural infection. So that would be, abortions and shedding of the organism. And there, in that situation, you would have the potential for animal-to-animal transmission and then animal-to-human transmission. And the S19 vaccine strain that was used from the 1940s until the 1990s, um, it interfered with any of the routine diagnostic serological tests. So an animal that was infected with a field strain of Brucella abortus could not be differentiated from a vaccinated animal that had been vaccinated with the Brucella abortus S19 vaccine strain, which was problematic at that time. So this is just some information on the vaccine strain. S19 is the original vaccine strain since the 1940s. And it's a smooth strain, meaning that it carries on its the side chain of its lipopolysaccharide side chain. And it was actually derived um, by spontaneous mutation from a virulent Brucella abortus strain that had been left at room temperature for 1 year. And this was back in the 1940s. That was kind of an interesting piece of factoid. But strain 19 is known to induce brucellosis in humans. And it does, as I mentioned, have the smooth cell wall um, phenotype, so it does cross-react serologically, which makes it difficult to differentiate between naturally infected animals and vaccinated animals. So this vaccine strain was replaced in the 1990s by RB51. So between the time that the eradication program was initiated from the 1930s and then it was enhanced in the 1950s, all the way up into the 1980s, and again, I'm showing this graph, we were really starting to see a dramatic decrease in human and animal brucellosis cases in the United States. So they changed the effort, the approach to eradication, and they turned it into a brucellosis emergency action plan because they felt like the USDA was getting much closer to actually eradicating this. So new cases were a high priority, and then again, they were depopulating affected herds. They were enhancing surveillance, and by 1997, there were only 86 affected herds in the United States. And this is some data that we pulled from the National Notifiable Disease Surveillance System database. And this is on average what is reported brucellosis cases, human brucellosis cases that are reported for the past 10 years or so. It averages between 80 to 120 cases a year. And cases are not reported by species. It's only reported as a brucellosis case. So we don't have within this system, in this database, um, true, species case reporting. This has come a long way since the 1930s, 40s, and 50s, when you were having, thousands of, human brucellosis cases in the United States. And these are the states that have or do routinely report more cases than others, and that's Florida, Texas, California. So now I'm going to move on to specifically about the Brucella abortus vaccine strain and what we've been encountering here in the way of human exposures to this vaccine strain. So the RB51 vaccine strain was licensed in February of 1996 by APHIS, USDA, for use in cattle as part of the brucellosis eradication program. This particular vaccine strain is a genetically stable, rough morphology mutant that lacks the polysaccharide O side chain. And I have an image here showing the specific element that is lacking in this particular strain. It's called a rough strain. There's a couple of other Brucella species that are also rough. Brucella canis is rough, and so is Brucella ovis. So they're also lacking this O antigen side chain. So RB51 was derived from the passage of Brucella abortus 2308 on selective media containing rifampicin and penicillin. So RB51 is resistant to rifampicin. In cattle, in its vaccine efficacy, it's considered less virulent, less abortogenic, and it's to be used in calves to be vaccinated with a calfhood dose between 4 and 10 months of age. So right now in the United States, vaccination with RB51 is no longer mandatory. It's just regulated at the state level. So there are some states that do use RB51 currently, but it's not federally mandated to vaccinate. So RB51 entered into the eradication program in 1996, and I've got here an image, pulled from USDA on the state status classifications of the states as of August 2013. The advantage of RB51 is that RB51 vaccinated animals do not react with standard serological tests, which was a really important feature for routine surveillance of the herds in the United States. So by 2008, all states in the U.S. are considered brucellosis free by the USDA, except for certain areas around the greater Yellowstone area. So slaughter surveillance has been reduced. Surveillance relies on a rapid serology test, which animals, if they're vaccinated with RB51, unless they were infected with a field strain or had natural infection, they would not react on these rapid serology tests. And similarly with the milk surveillance, they do a milk ring test, which is a very simple agglutination test with a color change that's performed on milk. So after the RB51 vaccine strain was put into use and S19 vaccine strain was basically retired, the CDC wanted to assess the risk that this vaccine strain would potentially have to humans. So they established this study to conduct passive surveillance for accidental inoculation with the RB51 vaccine strain in the U.S. And so they recruited volunteers to enroll in this study between, this is actually a 2-year time period. It was from January 1998 to December 1999. So, and in this time period, they had 26 veterinarians self-report their exposure with the RB51 vaccine strain. And all of them reported exposure via either needle sticks or spray in the eye or broken skin. 27% reported symptoms. And I have a table over here showing the majority of the symptoms that they experienced that were either shortly after their infection or they were delayed. So the sample size was really very small, but it was informative, but it was not enough data to generalize the findings on the true risk that this vaccine strain may have for humans. And just in summary, in the 22 years that this RB51 vaccine strain has been used now, there have been no casual consumer of beef or milk products from the U.S. That have been reported to be infected with RB51. Most all of the associated infections have been occupational, veterinarians or ranch handlers that are coming into close contact with animals, cattle specifically. So this brings us to what we're sharing with you all today, which is this exposure of RB51 to humans. And we did have a case in Texas where a case presented to a local hospital with symptoms compatible with brucellosis. So she had fever, malaise, myalgia. She had a known sulfa drug allergy. And so the physician at the hospital took a blood culture from which Brucella species grew and was referred to the Texas LRN lab, the Department of uh, State and Human Health Services. At that time, they had only really discovered that the major risk factor for this patient was consumption of raw milk. The patient was not she hadn't traveled anywhere outside of the country. She wasn't a farmer of any kind. She didn't have, she wasn't a feral swine hunter. So her risk factor really was just consumption of raw milk from a local dairy since the beginning of the summer. And the local lab in Texas that had initially received the isolate was having some difficulty identifying the species of this particular isolate. So they called our lab and asked us what we thought about, what they were seeing. And knowing that the consumption, the main risk factor was consumption of raw milk, we asked them, well, we had suggested that, they could be RB51, the vaccine strain, considering raw milk was involved. So they sent this isolate to our lab. We presumptively tested the isolate with this molecular test that we have in our lab that is not part of the normal LRN algorithm that is able to differentiate all the Brucella species and the vaccine strains. And by this presumptive test, this isolate did look like the Brucella abortus RB51 vaccine strain. And it wasn't until August 7th that we actually confirmed the isolate as RB51, where we had to complete all of the standard biotyping tests, including a phage test and urease and hydrogen sulfide, and it takes a long time to get the final identification through those standard microbiological tests. But as we had reported that we suspected it was RB51, and it had a rough agglutination phenotype on an acroflavin test, Texas Department of Health Services went to the farm and collected some bulk milk samples that they tested in their lab by PCR and then for culture, and they obtained Brucella isolates from all 4 of the bulk milk samples that they tested. We also received those isolates and confirmed them also to be RB51. And then at this point, we reached out to federal support at the USDA to the National Veterinary Services Laboratory to do individual testing on all the cows in the herd so we could try to identify how widespread the shedding in the milk may be. This dairy had 43 cows in their dairy herd. So they went and collected individual milk samples from each of those cows. Those went up to Ames, Iowa, to the National Veterinary Services Laboratory, where they did culture and PCR from each individual cow milk sample. And from that, they identified that there were 2 specific cows that were shedding milk, that were contaminating the entire bulk milk tank. And those 2 cows were removed from the milking process. And by August 8th, the Department of Milk and Dairy in Texas issued a recall order to the farm, a cease and desist, so they were no longer able to sell any products from their farm. We also did whole genome sequencing on all of the isolates that were recovered from this investigation. So we had the human isolate, and then we had multiple isolates from the bulk milk tank, and then the um, individual cows. So whole genome sequencing, and I'll show you some slides later, really showed the genetic similarity between the two shedding cows, and we could identify the exact cow that infected the human case that we identified initially. So the herd was initially, the cease and desist was issued, but we also had some blood samples taken to look at the animal, not just the milk, but at the blood of the animals. And so we ran um, ELISA, culture, and PCR on the other cows that were part of the dairy herd because the two that were shedding were removed. So after RB51 was identified as the um, strain that was infecting our index case, there was a lot of consultation with the infectious disease physician, and this patient had a drug allergy to sulfa drugs, and she was unable to take rifampicin because the strain itself is resistant to rifampicin. So she was transitioned to IV gentamicin and ceftriaxone, which was discontinued after 4.5 weeks or so due to side effects. So the patient had really limited options as far as her antibiotic therapy. And she had frequent consultations with many specialists and in the hospital. So she had a lot of monitoring, and she had a lot of complications with her antibiotic treatment. So, so we had this farm that had all this contaminated milk, and um, the most epidemiological defined data that we had for our index case was that she had consumed milk from this farm starting in June. So our next step was to identify additional people that may have also been exposed to this milk and gone to the farm and can purchase the milk from the farm, and to provide them information on their risk and how to seek health care and post-exposure prophylaxis. So the exposure was defined as anyone who consumed raw milk or products from the implicated farm between June 1st and August 7th. And this farm, which was very cooperative, provided a logbook from their patrons who had come to their farm that identified over 800 households who had purchased raw milk or raw milk products from their farm. And from that logbook, there were about 577 households that had complete phone numbers that we were able to reach out to. So Texas was not able to call all of these households, so they requested requested assistance from the CDC. So we opened up the Emergency Operations Center and recruited volunteers to work through the call list to notify all of these households that we needed to inform of their exposure risk. So in total, out of the 577, there were 377 households that were successfully notified. So that's a 65% rate of contact. Of those, 287, which is 76%, were verified their exposure. They actually had been exposed. They had gone to the farm. They had consumed the milk. And through all of these contacts, they were referred 34 additional households, an individual that had said, oh, well, my friend went and she wasn't on the contact list. And so we obtained more contact information of potentially exposed people. And the exposures identified, all of the contacts identified potentially exposed people in 7 other states outside of Texas. So after we had reached out to as many people as we could, there was aggressive public health, laboratory, and health care provider messaging on approaching diagnosis and treatment of RB51. Oh, excuse me, I didn't realize there was, okay. So we really did send out a lot of messaging, and I don't know how many of you on this call can verify this. You may have received some of them, but a clinician health alert was distributed to all public health officials at the state level, local, tribal, and territorial levels. A clinician outreach and communication activity listserv with over 100 partner organizations. And then the CDC's, we posted notifications on the CDC's emergency preparedness and response website as well. Our lab assisted in a drafting a laboratory health alert that we disseminated via the Laboratory Response Network to all labs in the United States that we also encouraged to distribute down to Sentinel labs within their respective states. And the laboratory HAN basically detailed biosafety information and diagnostic recommendations for um, potential or suspected cases of RB51. So this is a schematic of what the CDC recommendations are for RB51 exposures. RB51 is rifampin resistant, so doxycycline and TMS are the recommended combined therapy unless there are contraindications with either of those two antibiotics. They should consult with their healthcare provider. So treatment for RB51 infections is a minimum of 6 to 8 weeks, depending on the complexity or the localization of the disease. For those people that were exposed, we did recommend 3 weeks of post-exposure prophylaxis and then 6 months of symptom watch. So as of October 6th, the dairy farm has returned to selling raw milk and raw milk products. The 2 cows that were identified as shedding um, the vaccine strain in the bulk milk were removed from the herd, and the herd was tested repeatedly by culture and PCR in fresh bulk milk that was collected after they had opened back up. They they destroyed all of the milk that was in the bulk tank upon the cease and desist, and then they refilled it back up, and they're still undergoing continual testing on a monthly basis. So, and as of October, there's another unrelated brucellosis case caused by RB51 via consumption of raw cow milk that was reported in New Jersey. And that investigation is still ongoing. So this is the final section, and it's really just a summary of how our recommendations for diagnosing routine human brucellosis cases, and then the challenges that we've faced with these human infections with Brucella abortus RB51. So the laboratory criteria for diagnosis based on our brucellosis case definition are culture, which is a definitive diagnosis, or evidence of a fourfold or greater rise in Brucella antibody titer between acute and convalescent specimens. A presumptive diagnosis is just a single antibody titer greater than or equal to 160 by a standard agglutination test, or BMAT, which is the Brucella microagglutination test, in one or more serum specimens obtained after the onset of symptoms and or the detection of Brucella DNA in a clinical specimen by PCR. So this is not for RB51, but the most common diagnosis of brucellosis is by serology. There are many different ELISA assays that are performed in commercial labs or at the Sentinel level and private labs, and they are um, able to detect IgM, IgG, and then total antibody. At the CDC, we perform the Brucella microagglutination test. And this test is basically a modified version of the serum agglutination test, which is, it involves, an observed agglutination that you would see between a crude cell lysate of, Brucella abortus with whatever antibody that may be roaming around in the patient's serum. This particular assay and most all ELISAs can only detect infection caused by the smooth species and those that infect in humans, Brucella abortus, suis, and melitensis. Um, the whole cell preparation antigen is obtained from the National Veterinary Services Laboratory for our Brucella microagglutination test, and it's the Brie abortus 1119 strain. So this test is most suitable for acute, non-complicated cases, and for a definitive diagnosis, it's best to have paired acute and convalescent specimens that are about 2 weeks apart. So you're looking for a titer of greater than 1 to 160 with a fourfold rise, which is considered evidence of acute brucellosis. And in some countries, they use a higher cutoff in endemic countries, which would be 1 to 320. Brucella culture is performed fairly routinely here in the United States, and it's considered the diagnostic gold standard. And positive blood culture among acute patients ranges between 50 and 80%. So even if you have an acute case of brucellosis, you may not even get a blood culture. The best yield is from blood. Seems to be the most common specimen from which Brucella is isolated, but you also have with brucellosis a lot of localized infections. So um, local abscess material or aspirates from localized infection areas are also optimal specimens for culture. And it's best to obtain these before antibiotic treatment. So isolation in the U.S. typically occurs at the sentinel or clinical lab level, and it's important when a physician sends a blood culture test to um, sus- indicate that there's a suspicion that Brucella may be on the differential, so that these labs may hold the blood bottles for longer than 48 hours or 72 hours. Sometimes it's best to hold for up to 7 to 10 days for Brucella. So once an isolate is recovered, it's important, and it's suspected to be Brucella, it's important for the isolate to be submitted to a local, to your LRN lab or for confirmation. And then at our lab at the CDC, we do a lot of various genotyping and characterization methods too. So working with Brucella isolates, just to reemphasize, it requires a BSL-3 and trained technicians. There's a lot of biosafety risks handling the Brucella species outside of this containment level, and it leads to a lot of laboratory infections or exposures if it's not handled appropriately under the proper safety conditions. So these are just the characteristics of Brucella species. It's a member of the alpha proteobacteria class. It's a gram-negative cocobacilli. It also can be gram-variable. It's small, round, smooth, honey color. There's an image here of what it looks like on a standard sheep blood agar plate. It's facultative and intracellular. So this is our laboratory identification schematic, basically, and a lot of you out there use this same test flow. Our lab really receives a lot of just already purified isolate cultures. And from that, we'll set up all of the biochemical tests. And some of these tests have dropped out of the algorithm. We don't do the dye tolerance anymore or the gel formation, the slide agglutination, but the last four, the gel formation and the phage test and the hydrogen sulfide are tests that we are still actively doing with the LRN. We do actually receive a lot of clinical specimens from suspected brucellosis cases, tissues and serum and blood and joint aspirates. That seems to be a common specimen that we get in abscess material. So we do also, in addition to the standard biological tests, we do a lot of higher level characterization, and we have some molecular tests that we use in addition to what's available with the LRN for differentiating the species and subtyping, and then whole genome sequencing is something that we've really just kind of started to bring on board, and trying to integrate it as a routine method for us when we receive reference specimens. So this is a little blurry, but so this is basically how you key out the species with the tests that we do, which are the hydrogen sulfide, the urease, the gel formation, and the phage. And then there's the LRN PCR. And if you look at this table and knowing that an individual may be infected with RB51, RB51 doesn't fit in any of these. You can't key it out, and it really can be confused with melitensis um, in its phenotypes. So this was a table in the bottom that we included in our laboratory alert, our health alert that we sent out via the LRN. We made a modification to the table to show labs what they may see if they come across RB51. This is what it may look like on the standard test that they would be running. But more specifically, that it is a Brucella abortus strain, but it does not show any lysis on either of the routine test dilutions of the phage, which you would expect to see with a field strain of Brucella abortus. And so here too, you can see that melitensis and canis also show no lysis. So there is this PCR that we have been using in our lab for a long time, and it is called the Brucella PCR, and it was developed by Lopez Goni, and we implemented it not as a CLIA test um, back in 2008. So we have a lot of validation data on the effectiveness of this PCR to really differentiate um, species and compare that with the gold diagnostic standard of all the biochemical tests that we also run alongside it. So over the years, we've obtained enough data to validate this PCR, and it is able to differentiate all the species in the vaccine strains. And we have recently obtained ISO 17025 accreditation for this specific test in our lab on bacterial isolates. So when we receive an isolate, we can rapidly run this PCR and have a presumptive idea of what it is. And it just helps us give an idea of where potentially, epidemiological follow-up may need to go faster than waiting until it's been confirmed 7 days later. So we have a very good relationship with our National Veterinary Services Laboratory in Ames, and they have a really phenomenal whole genome sequencing analysis pipeline that we have now coordinated on analyzing human and animal genomes together in the same data, in the same way, and in the same database. So they presented this at this conference that we just had a couple of weeks ago. And what you're seeing here is basically a phylogenetic tree of Brucella abortus. And within it, you can see down at the bottom, those colored in red are RB51 strains that they have in their database. And in that are included all the isolates that have been recovered from the milk from the farm in Texas and the human case, both in Texas and in New Jersey. So we performed whole genome sequencing on the human isolates, both from Texas and New Jersey, and USDA has done all the culture and whole genome sequencing from milk and tissues of the cows that after they were they went to slaughter, and so the tissues from those cows went up to the National Veterinary Services Laboratory for culture, and they obtained a lot of isolates from those tissue samples. So the SNP analysis, which I'll show you on the next slide, shows direct linkage between the Texas case, human case, and exactly one of the cows that was shedding the vaccine strain in their milk. So this is a picture of the SNP table. It's a single nucleotide polymorphism table. And you can see here, I know there's a lot going on. Excuse me. The strain 2308 is the parent strain of RB51. And So they've got everything nicely color coded, so you can kind of walk through it if you took some time to really read through. But you can see that um, in the RB51 isolates, which basically start about where the top three purple colored isolates stop. All the ones below that are RB51 isolates, and you can see there the mutation that's associated with the rifampin resistance and the other, four mutations that are very specific for RB51. And then subsequently, you can see all the different variations that all these RB51 isolates that have been recovered, not only from just the investigations that I'm talking about today, but they have isolates in here that are not colored, but they've recovered from aborted fetuses or cattle from other parts of the United States, so just through general surveillance. But what you can see is the human case down here at the very bottom in pink from Texas, and the direct correlation with the cow isolate that was shedding. So it's the nearly identical strain that she was infected with. So this is really helpful to have this level of discrimination, to be able to really, I mean, this is very epidemiologically effective to be able to see this level of resolution. So in general, RB51 laboratory diagnostics, so there's no serology assay available to detect RB51 antibodies in humans. And culture and identification, culture is recommended, but handling Brucella requires BSL-3 facilities, and if there is an RB51 isolate, the phenotype is not typical of Brucella abortus, and it can be confused with Brucella melitensis. Direct PCR from clinical specimens is an option when culture is not possible, but it's often difficult to base diagnosis on a direct PCR test result. There's such a limited bacterial load in a blood specimen that you could get a false negative. And by not having an isolate or attempting culture, it limits further genotyping capabilities, such as whole genome sequencing, that is really helpful in these types of investigations. So these are just the two laboratory notifications that we sent out via the LRN, and we had one specifically drafted for our state LRN labs, and we had also attached one that was specific for Sentinel laboratories. And the information that we put in these two were slightly different. I mean, they were similar but slightly different. There was certain information that Sentinel labs that wasn't so relevant for them. But we really wanted to emphasize the biosafety, that when handling suspected samples of Brucella, that it should be clearly labeled in every way that there is suspected Brucella species in that specimen. And then when handling the specimens, to wear proper PPE, and when possible to work in a certified biosafety cabinet. And then for the LRN labs, we just really wanted to break down the differences between the phenotype that you may see with RB51, and that certainly if you cannot identify, the species of a particular isolate, you can always refer it to us, and we're happy to confirm the identification. So conclusions and unanswered questions. So this case in Texas was first known case of Brucella abortus strain RB51 in a human via consumption of raw milk acquired in the United States. So this has increased awareness, and this investigation has led to the identification of at least one unrelated case in New Jersey. And so there's a lot of questions. I mean, we've been talking with leaders and, at the federal and state and local levels. And so there's a lot of questions. What is the magnitude of shedding of RB51 in vaccinated cattle? And is there a need to develop serological assays for RB51 and validate them for use in animals and in humans? And or to rethink the testing strategy for raw milk dairies that use RB51. And then, of course, is just the tip of the iceberg for what we're seeing right now. So these are acknowledgments, and I included Texas DSHS here because they have been doing a lot of heavy lifting in Texas with a lot of the investigations on the case and with the farm, and they're still working through some of the information and the data. And then, of course, the USDA is a perpetual partner with us in anything that we do, and so I just want to thank them. And then that is the end of our presentation.